Good evening, ma'am, and all the participants. So, today's speaker is Dr. Silpa Bhatia. Her designation is consultant hemato-oncologist and BMT specialist Parkview, Super Specialty Hospital, Kolkata. Her area of interest is in hematoglobinopathy, multiple myeloma, leukemia, and bone marrow transplant. The class is over to you, ma'am. Thank you.
Hi, good evening, everyone. Today, I will be taking a 1-hour class on hematological malignancies. So hematological malignancy, they will ask you specific questions mainly related to diagnosis. And I think more and more nowadays, molecular diagnostic paths have increased. So they would expect you to know some very classical chromosomal abnormalities that are found. So they'll be giving certain hints. Sometimes hematological emergencies may be asked because that is something people have to know in their MRCP, whether they are doing an emergency post or acute medicine post. So, they may be related to some of the hematological malignancy. Yes. So the first question, 65-year-old Caucasian gentleman has come to the clinic with acute promyelocytic leukemia. Okay. So they've given you the diagnosis over here. Which of the following is the most likely mechanism for the underlying leukogenesis? Who's going to take this question? Dr. Sneha Singhi.
Hello, ma'am.
Hi. What do you think is going on over here? What is the pathology for APML? Anyone knows what is the classical pathology of acute promyelocytic leukemia? It's a type of leukemia, isn't it? AML. AML has got many subtypes, out of which APML is the M3 version. And it happens due to a combination of two genes fusion, right? Can anyone tell what are the two genes?
922.
922 is not in acute promyelocytic leukemia.
Madam, 15:17.
Yes, exactly. So you have a translocation 15-17, that is aberrant fusion of two genes, the PML and the RARA gene. Okay, in APML, the result of chromosomal translocation 15-17, and you get two genes, the PML RARA fusion gene. Okay, so the correct answer is it is a result of fusion. So if you go back, you will see you don't get telomere shortening. It's not the other things. It is aberrant fusion of two genes. And the genes are PML RARA, and the translocation abnormalities is 15-17. Good. Next question will be for Dr. Deepashree Bhattacharya. 47-year-old lady treated for acute myeloid leukemia. Now she is not getting sufficient rises with her platelet transfusion. She has received chemotherapy 16 days ago. She is currently well, apyrexial, and she has got only minor bruising. So she is doing fit and well otherwise. But whenever her platelets are low and we are giving platelet transfusion, she is not getting increment. Which of the following would be the next step in management of platelet refractoriness? Not incrementing is called platelet refractoriness. So which is the next best management? So what are you going to do? How do you manage platelet refractoriness? Do you check 1 hour post platelet count? Do you give directed platelet donations? Do you give HLA matched platelets? Do you just monitor with random platelets? Or do you avoid further transfusions? Quick, either answer or say pass.
Pass.
Okay, anyone else? Okay, so platelet refractoriness is something that happens as a result of repeated platelet transfusions. The best way to prove it is you have to check the platelet count 1 hour post platelet transfusion. And none of the options are as such wrong. But what is the most next best step? So the question is the next best step. So you will check 1 hour post platelet to confirm that there is refractoriness. Directed platelet donations can be done, but it takes a lot of time. HLA matched platelets may be the treatment of choice, but not in this situation because this lady is currently apyrexial. She's only got minor bruising. So, but we can't just go on giving random platelets and keep monitoring count rises because it will not happen. Once they are refractory and you keep giving random platelets, there'll be no increment. You're unnecessarily loading the patient with plasma. And you cannot even avoid further platelet transfusion because she may have severe bleeding. So in this In this scenario, you would check for adequate platelet rises for patients who are refractory. Okay. So the next question is 76-year-old gentleman.
What's the reason for this refractoriness? Why aren't they increasing in
They
these
develop,
patients?
okay, yeah, so they develop HLA antibodies. You know, you're giving, what do platelets contain? They contain plasma and platelets. So when you are exposing a patient to multiple plasma, you are exposing them to HLA antigens. And as a result of repeated antigen exposure, your body is going to make antibodies. So they make the antibodies against the HLA, which is represented on the platelet surface, or also the human platelet antigen, human leukocyte antigen, and HPA antibodies. So as a result of repeated exposure, your body makes antibodies. So whenever you are giving them platelets, those antibodies will promptly attack those platelets, and you will not see the increment in the blood report. So first time, if any,
Thank you.
If first time a patient is getting platelet from 10,000, you will see platelet has gone to 50,000, but you keep giving them, next time 10,000 will remain 10,000. It will not increase. And that is called platelet refractoriness. Okay, so the next question is 76-year-old man managed at Hematology Oncology Clinic for suspected myeloma. He complains of increasing shortness of breath for few weeks with lethargy, decreased exercise tolerance, and bilateral lower limb swelling. He looks pale, blood pressure is normal, pulse rate is normal, heart sounds are normal, but he has got some crepitations on auscultation of the chest, and he has got pitting edema. Look at the blood reports. It is showing that his hemoglobin is reduced, leukocyte normal, platelet normal, sodium, potassium normal, creatinine is slightly elevated, albumin is very low, and urine protein is +++. So the question is, what is the cause of his underlying proteinuria? Who is taking this question? Dr. Bihina Suleiman?
Ma'am, option A, amyloid light chain AL amyloidosis.
Okay, explain it. You're correct. Explain it.
Ma'am, in multiple myeloma, there will be light chain amyloidosis.
It's not that all patients of multiple myeloma have amyloidosis. Some of them can have a coexistent amyloidosis. And if you look at the investigations, the giveaway is the significant urine proteinuria with a very low albumin and slightly deranged renal function. So this is, and they said it's a suspected myeloma. So you have to know that you are talking about a plasma cell dyscrasia. None of the others are plasma cell dyscrasia. The only plasma cell dyscrasia over here is option A. Right? So it is caused as a result of multiple myeloma, and you cause deposition of immunoglobulin light chains in the renal cortex, which causes amyloid deposition, and you get leakage of protein, you cause fluid retention, and you get a picture of heart failure and proteinuria. It's likely that the light chains can be easily detectable in the urine because you know that the protein albumin level is very low. In the other comparison sort of confusing option is A amyloidosis. Okay, we know this is not a neoplastic disorder. This is a reactive amyloidosis in conjunction with autoimmune diseases. And the other option, cystatin, I mean, you know, you have to exclude. Even if you don't know, you have to exclude. The cystatin C is in conjunction with Icelandic hereditary, I have no idea also what this is, hereditary cerebral hemorrhage and amyloidosis, and beta protein precursor with Alzheimer's disease and Down syndrome. For underlying myeloma, treatment is same like chemotherapy, same like the myeloma chemotherapy. Okay, if anybody doesn't understand anything, you please have to stop and ask. For me, this is daily stuff, but you may find it all Greek and Latin. So please stop and ask me when you don't understand what is the explanation. So next question, which of the following statements is true regarding polycythemia rubra vera? First of all, do you all know what polycythemia rubra vera is?
Can you explain, please?
Does anyone know what is polycythemia vera?
It's primary polycythemia, isn't it? That blood cancer of red cells.
Yes, so it's not really blood cancer, but it's a myeloproliferative disorders in which it is a mutation-driven pathology. The gene JAK2, which is responsible for controlling your RBC production, is mutated. It is called JAK2 mutation, JAK2. That mutation, the gene gets mutated and there is continuous production of hemoglobin, and they get polycythemia when the hemoglobin is more than 18 in men and more than 16 in women, with a hematocrit, can vary anywhere between 50 to 60%. Okay. And as a result, the blood is very thick and it causes all the thrombotic disorders. It can cause strokes, it can cause heart attacks. So which of the following statements is true regarding polycythemia vera? Venesection treatment will improve long-term survival rates. PRV may be characterized by a raised packed cell volume and a decreased plasma volume. The diagnosis of polycythemia rubra vera can be made based on a high red cell mass, reduced EPO, and characteristic bone marrow findings. Polycythemia rubra vera is usually associated with high hemoglobin, but with neutropenia and thrombocytopenia. PRV is often associated with hypertension and smoking. So which of the statements is most true?
Is it C, ma'am?
Madam, B, I think.
I think C.
You think C?
Yeah.
Yeah.
E seems to be the most probable one.
Yes. So who's the one who said B? You don't get decreased plasma volume. Okay. That's why it's not B. You are getting definitely raised packed cell volume, but you're not getting decreased plasma volume. It is a relative decrease. It's not an actual decrease. So that's why it's not really true. Venesection will help ease the symptoms, but it does not change your long-term survival rate. So the correct answer is C. And that is based on the WHO criteria for the diagnosis of PRV. Okay. Major is hemoglobin more than 18.5 and 16.5 in women, elevated red cell mass, and as I said, presence of JAK2 mutation. It's not 617VF, it's V617F. And the minor criteria is below normal serum erythropoietin, bone marrow showing hypercellularity with more of, all tri-lineage proliferation, and this colony formation nobody checks. Okay. So these are the major and minor criteria you need to remember. And all those things they used to check for oxygen saturation to see whether it's hypoxia driven, the spleen size, the platelet, and the white cell count are often raised. So the answer where leukopenia and neutropenia was there, no, that is a wrong answer. The raised PCV is caused by a decreased plasma volume. As I said, it's an apparent or a spurious polycythemia, which may be associated with hypertension or smoking. In actual PRV, it is high platelet count, high white cell count, while associated with raised hemoglobin. And though there is no evidence that venesection is improving long-term survival, but it is still the treatment of choice because it reduces the rate of immediate thrombotic complications. Okay, so it is kind of, it's red cell malignancy. Yeah, you can call it as a myeloproliferative neoplasm. So you don't scare the patient by saying they have cancer.